right, good afternoon, everybody. Thanks for coming. I have a distinct pleasure to introduce Isabel today for a grand rounds. You all know Isabel. Just to give you a brief background, she did her MD at the University of Rochester in New York, and then she came to Yale, so she is homegrown. She did internship, did her residency here and her fellowship, and has been on faculty now for 5 years as an assistant professor. And she's a highly valued member of our airways disease team. And she's going to talk to us about equity in pulmonary function testing, history, updates, and impact. Please give her an applause. Thank you.
All right, thank you so much. I'm really honored to be here and speak with you all today about this topic, which means a lot to me. It's a topic that I think we are all still learning about. It's a topic you think you might have known, and I hope I will shed more light on what we didn't realize we knew. I actually didn't start with this initially, but, oh, I'm sorry, before I begin, please use this number for your CME, and I have no financial disclosures to share. Okay. So we're going to talk about the history of spirometry, how we came to interpret spirometry in the way that we do, why we have included a race adjustment, what our new race-neutral equation means, which I think everyone knows has been the new ATS official statement, and then most importantly, what the impact for our patients is. And I think I'll share a personal story, maybe in the midpoint. I just decided. Okay, great. So first we'll start with the history of spirometry. So before 1840, we weren't really able to measure what someone's lung function was until John Hutchinson, who was a British physician, invented the first spirometer. And he measured vital capacity alone, and he found that it increased with height, it declined with age, it seemed to be different between the sexes, and also seemed to vary by occupation and social class. So these were some of the very earliest observations that he was seeing, and he was using some statistical methods to sort of determine what normal values might be. And then we started to use spirometry more regularly through the late 1800s and early 1900s for the diagnosis and monitoring of chronic lung disease. And then in 1947, a French physician named Robert Tiffonot introduced the idea of time spirometry, which gave birth to FEV1 and FEV1-FVC ratios. And then it wasn't until the 1960s that we found out smoking is bad for you and bad for your health, and maybe we shouldn't be basing our normal lung values with people who are smokers. And so that led us to 1971, which was this study with James Morris, who took a group of non-smokers for the first time and to get an assessment of what normal values were. And I wanted to highlight within his paper here that he looked at 988 healthy non-smokers, men and women, and noted that there was wide variation that he encountered that was not attributable to age, sex, or height, and he felt that there was more research to be done as to why that was. In 1979, the ATS released its first of many to come official statements about spirometry, and said that we should probably all be doing this the same way. Let's make a protocol. Let's try to minimize measurement error. And then there was a follow-up in 1989 that talked about calibration and training our technicians the same way, and reproducibility. And so that's when that was happening. Throughout this time in the 1970s and 80s, from what I can see in the literature, we were already introducing a race factor, and we were already decreasing the values that you got by 10 to 15% for Black patients. And I'm going to go through the history of how that came to be. But we don't get our big data set until 1999. This was the NHANES study, which many of you may have been familiar with and may have been training at the time that this was the PFT interpretation used. So the NHANES study was a National Health Nutrition Examination Survey. There was 8,000 or less than 8,000 non-smokers included between the ages of 8 and 80. And they found, again, there were differences in adjusted for age, sex, and height. And they also felt that, statistically speaking, there were a few trends that seemed to separate. And so they found that there was Caucasians, African Americans, and Mexican Americans seem to have different statistical trends. And so they felt that there needed to be also a correction factor for those. So after NHANES in 1999, we had 4 reference equations that you could use: Caucasian, African American, Mexican American, and other. And that was the standard officially made by the ATS in 2005. Then we get to 2012. This is a Global Lung Function Initiative. And this was a cross-sectional study of nearly 100,000 people. So comparing to what was about 8,000 patients, now this is 100,000 patients, so much larger. But again, think about representative what our global population is, still quite a fraction. And they found, you know what, I'm actually not seeing a difference between Mexican Americans anymore, so let's throw out that category. And let's instead, we're actually seeing differences now between white, African American, North Asian, and Southeast Asian. And then again, had an other category that there felt that wasn't enough in that category to say more about them. And this became our standard for ATS interpretation until 2023. So I'm going to pause here. Yeah, I'll pause here and share that I had my PFTs done when I was a fellow on my PFT rotation. So you get to know what it's like, get to know what your patients go through. And I was doing it at the same time as a resident who was rotating on with me. And she and I were of similar heights. And I was noting that our percent predicteds were quite different from each other, even though our absolute values were pretty similar. And I asked my attending at the time, who is not here, and he said, oh, well, you're Hispanic, and so your thorax is smaller, so we need to use a different equation for you. We need to adjust for that for you. And I was like, what does that mean to be Hispanic? Like, are all Hispanic people the same? Genetically, what about being Hispanic is making my thorax different than hers? And so I think that is what birthed a lot of questions about this and to learn more about it. So why do we correct for race in the first place? How did this originate? So this started back before we were even able to measure lung function. This was in 1785. This is Thomas Jefferson. And he wrote notes to the state of Virginia stating what he thought about the difference between slaves and white people. And he felt that these differences, including brain size, including tolerance of heat, including tolerance of pain, and including the pulmonary apparatus, were different. And that there was a difference between these structures because one was inferior than the other. And he was making all of these statements without any scientific evidence behind him. These were just theories that he was putting out into the world. In 1840, as I mentioned, John Hutchinson invents the spirometer, and these are some of the classifications that he made on his initial observation, which I said not only accounted for age and gender, but also many different types of occupations and social class, which I think is important to note. Then we have 1860. Samuel Cartwright was a physician and notably also a plantation owner. And he was one of the first to document in a medical journal these differences between lung function and racial groups. He published a manuscript in the New Orleans Medical and Surgical Journal, which I will note is also a journal that talked about drapetomania. I don't know if I'm pronouncing that correctly, but it was a disease that he felt inflicted slaves. Anyone who wanted to be free had this illness. And so there was, I think, a lot of pseudoscience in this journal. But he said that he described these differences between races in the respiratory system, and he felt that because Black lungs are inferior, therefore it is appropriate, the appropriate treatment would be forced manual labor. So this was all a justification of slavery. We get to 1870, around the same time. Benjamin Gould's an astronomer, but with a lot of I guess, ability to manage large data sets. And so he was one of the first to do a large scale anthropomorphic study comparing Black and white Union soldiers. And he also noted that Black soldiers seemed to have a lower lung capacity or vital capacity than white. And he made no adjustments for working conditions or living conditions, and attributed the difference to biologic differences between them. There were some people around the same time in the late 1800s that were disagreeing with the conversation that was going on. This is James McCune Smith, who was a physician and an abolitionist, and he said, we are not considering the climate when we're making these comparisons between races. In the 1900s, W.E.B. Du Bois was a sociologist, and he wrote that this association between biology and race is prejudice, and we should not be doing it. And that brings us to 1925, which was the earliest document that I was able to find that talked about how we should be adjusting our reference equations or our interpretation of race. And so this was a book called Vital Capacity of the Lungs, and they talked about all the different things that can impact your vital capacity. And so this was the chapter 2 called Factors Other Than Disease That Influence Normal Vital Capacity of the Lungs. So there was a section first on occupation, and they decided that there was 3 different types of occupation that could lead to different types of lung capacity. Sex, age, obesity, and posture were also written about. And then they also stated that race and nationality seems to impact what your vital capacity is. And the data that they use to make those claims, so there was one study by Wilson and Edwards who looked at 38 children and found that they were, quote, average normal colored children between the ages of 4 and 18 years old, and that their lungs were they're significantly lower vital capacity and therefore recommended a racial correction factor for everyone. And they also found that a group of a group of 500 Chinese workers also had a, quote, much lower vital capacity, and that there should also be a race correction for them. And so this is some of the early data that's being used to determine what our normal values should be. We're from the very beginning saying that we need to make an adjustment for race, and this is the quality of research that it's coming from. So are racial differences linked to genetics? A lot of that theory came from racist beliefs initially, but what do we know about that from true science? So before we were able to sequence the human genome, one could have believed that each race has its own, is separate genetically speaking. And what we now know is that we are all very genetically similar. And in fact, 2 people from 2 different tribes in Africa have more genetic diversity between them than any 2 different races. They have the most genetic diversity since they have had the longest time to evolve their genetics, since that is where people began. And everyone else outside of Africa has all evolved from some of the same ancestors that initially left Africa. So I think that is hopefully the main debunk of whether or not there's an association here. This was a study I wanted to talk about the difference between race and ancestry. You might say, like, well, even if race isn't biologically determined, certainly your ancestry is biologically determined, or has some biology or genetic input from it. And so what is the connection between race and ancestry? How well does race approximate ancestry? This is a study from a genetics journal that came out, I believe, in 2015, looking at more than 100,000 or 150,000 23andMe customers, and compared what their ancestry was compared to their self-reported race. And the table here is showing the mean. And so the mean of those that self-identified as African-American, their ancestry was actually 73% African-American and had about, on average 24% European. But it's important to note that there was actually a wide variety of this. So this table actually shows some of that variety, that someone with almost 50% African ancestry might still identify as European. The fact that above 30% is about here, all of these pink lines are showing people who identify as European but have more than 30% African ancestry. So what percentage of African ancestry or ancestry from here or there is making up what size your thorax is going to grow to be? I like this because it shows the heterogeneity, not only that we might have variety between people, but that matters where in the country you're from. So this is looking at Latinos in the US and their percentage of ancestry, either of African, which is up here in the purple, of European, which is in the red, and then Native American, which is here in orange. So for example, if you're talking to a Latino in Texas, they have much more Native American ancestry than, let's say, a Latino from Florida, who's going to have a much higher percentage of European ancestry. So that has a lot to do with history, where people migrated to, et cetera. And so even though the mean of a Latino person might be 65% European, that's certainly not the case if you're in Texas or California. And of note, I'm 50% indigenous and I'm from New York. So anyway, And then when we talk about African ancestry, what are we talking about? Where exactly are we talking about? There are different regions, and this was a study looking at the different types of African populations, Senegambian, coastal West African, Nigerian, and Congolese. And you can see that in Africa, there's pretty much one dominant genetic ancestry based on the region that you're looking at. But in the Americas, it's pretty heterogeneous spread between all four of those, again, because of how those people with African ancestry came to be in the Americas. I hope we all historically remember how that happened. And so even when we're talking about African ancestry, we're still talking about a diverse genetic ancestry. So this isn't really a good analogy to use. There have been studies that have looked at lung function. So let's bring it back to lung function. This was a review looking at different studies that compared degree of African ancestry and asthma outcomes. And I want to look closer at this first one that found that increasing African ancestry was associated with lower FEV1 and lower FVC. So this was a study by Kumar from 2010, and they found that the higher degree of African ancestry you had, the higher percentage, the lower your FEV1 was going to be. This was in men and women. But I want to take you to the discussion section where they say, the association between lung function and ancestry found in our study may be the result of other factors other than genetic variation, such as premature birth, prenatal nutrition, socioeconomic status, and other environmental factors. So we're never accounting for those other environmental factors when we're looking at these differences. So what actually does underlie the differences in lung function that we're seeing? So talking to a rheumatoid pulmonologist, I don't have to tell you that there's lots of things that can contribute to what your lungs will grow to be, whether you were born premature, your early life experiences, infection, nutritional status, socioeconomic status, the air quality that you're breathing in, all of these things are going to matter. So what are some studies that have actually taken these things into account? This was a study from the Greater Cincinnati Asthma Risk. This is of children looking at the association between degree of African ancestry and readmission rates of asthma. And they found that this is the table here on the left, the more African ancestry you have, the worse asthma, the more likely you are to have asthma hospital readmissions. But then they found that when you actually take into account hardship, disease management, and exposures, that difference went away. This was a study that was done here in New Haven. You'll see some familiar names here, one of our former fellows, Ann Minardi, who was looking at where all of our emergency room visits for children with asthma are coming from in the city of New Haven. And we found that regardless of race or other comorbidities, they were mainly coming from these three complexes, these three housing complexes. These are all public housing complexes, and they were all in historically redlined neighborhood. So actually, the history of historical redlining was more important of a factor for asthma admission than race was. So this study I really like because it was sort of reanalyzing past data. So this was in the Blue Journal that was just published in 2025, looking at social determinants of health and the racial disparities that we initially saw in the NHANES data. And it was saying, let's take the group of people that we had, and all the colors signify different races. You can see the legend there of what they all signified. And let's account for different social determinants of health, job status, socioeconomic status, maternal smoking, obesity, et cetera. And let's see how many people we have left that are actually the quote healthy population where we're looking at normal lung function. Not only do you notice that, of course, the number is significantly decreasing because, of course, a ton of people have different social determinants of health that are impacting their lung function, but that the other colors outside of pink are significantly disappearing. And so we really don't have any data on those races that don't have those social determinants of health impacting them. This was the same study, again, looking at the differences in FEV1. So let's look at this top B, because this first side, A and C are children, B and D are adults. Looking at the difference between FEV1. So the higher up the dot is, the more different or further below the FEV1 is below the lower limit of normal. And you can see before any exclusions of social determinants of health, this blue line, which is non-Hispanic Blacks, was quite different, and it came down significantly after exclusions. So I'll summarize here to talk about what I hope you have seen as some of the problems with the race-specific reference equations. The differences between races started with racist beliefs and without consideration of environment. That's where we began. Now, continuing that on, may be masking potentially modifiable risk factors of reduced lung function. And we may be underestimating disease severity by making this racial correction factor that might contribute to disparities and different diagnoses and management of lung disease. So what happened? 2023 comes and ATS makes an official statement to say we should now use a race-neutral reference equation. And I want to note that in this manuscript, if you have read it, the authors say not all authors on this manuscript agree that we should be doing this. So this was already controversial even in their official statement. So what is this race-neutral equation and how is it different from the race-specific equations? So the race-neutral equation basically just reanalyzed the data from the GLI 2012. They reanalyzed it the same way using age, height, and sex, but they eliminated race as a variable. But they didn't want to, so this is not a completely race-blind equation. They still noted that the percentage of people they had in their population that they were looking at was still majority white. And so they instead weighted the equation based on the number of people they had in that group to be able to make it neutral between all the races. So they really wanted it to be an overall representation of distribution of lung function across the populations. So it's not independent of race, race-free or race-blind, but race-neutral. And the question I think we all want to know the answer to is how is this going to impact our patients? What change has this had and what change will it have for our patients? And I think there's much more data that needs to come out about this. So this was a study that was in JAMA that came out pretty shortly after the ATS statement by the same authors of the ATS statement that were showing the changes from one academic center, PFTs that were done over a decade of time. I think there was like 8,000 patients that were had compared the race-specific equation versus the race-neutral equation and how was their FEV1 changing. And they did it for all the different spirometry values. I'm only showing here the FEV1. And so in general, white patients seem to have a higher Z-score. The x-axis there is the change in Z-score. So they went to a slightly higher Z-score and Black patients went to a lower Z-score. This was a very similar study that was published in 2024 from JAMA Pediatrics, looking at the impact of the race-neutral equation on children. And so they also looked at, I think, 2 different academic centers, and they compared the 2 different equations. And so again, they found that white patients seemed to have higher Z-scores and Black patients had lower Z-scores based on the different equations. How were they changing in terms of category of impairment of lung function? So this is again from that same study. They looked at how many people moved category. So the first graph here, graph A, is white patients and this is Black patients. And you can see here that the thickest bars are people going from either restrictive or nonspecific to normal. And there were very few moving to other categories. And you can see here for Black patients that there's a large number of Black patients who were normal or categorized as normal and are now being categorized as something abnormal. This study was more recent that came out in 2024 from the New England Journal. I thought it was 2025, but it says 2024, so I was wrong about that. New England Journal looked at 5 different cohorts of patients, so more than 500,000 patients, so one of the largest studies looking at what the impact is. Here, they did something statistical that I have been trying to work on for a while. They looked at the discriminative accuracy between each reference equation. So which equation better discriminated whether a patient was going to have certain outcome. Because they already knew what the outcomes of the patients were. So they already knew which patients had wheezing, had shortness of breath, had died, had a diagnosis of asthma, et cetera. And so they tried to see which equation was going to better predict these outcomes. And they found that the discriminative accuracy was very similar between the 2 equations. So it was very similar discriminative accuracy for finding respiratory symptoms, healthcare utilization, new onset respiratory disease, or death. So didn't seem to find much of a difference, but where they did find a difference was in the categorization of disease. So this is looking specifically at COPD, and I think most of the data on how these new race-neutral equations are impacting our patients are in COPD. So this was looking at the number of patients that are categorized as moderate to severe COPD based on the GOLD criteria. And you can see here, I'm sorry that I didn't put in the legend, that the light color is race-specific equation and the bolder color is the race-neutral equation. So you can see here that there's not too much difference between the Asian and other racial group. In between Black patients, it seems to be that there's many more categorized now as moderate to severe than there were before. And then it slightly decreases for white and then slightly decreasing overall. This was a study that looked at lung function. This was spiromics, looking at how well the two equations correlated with symptom correlation. So this was looking at the CAT score and the St. George Respiratory Questionnaire. I think the CAT score is here on the right side, and the St. George is on the left side. And they saw that the race-neutral equation, so this top one is the race-specific and the bottom is the race-neutral. You can see that the values are much more correlated, better correlated, the two lines here are much better correlated on the race-neutral equation than they are on the race-specific equation. So this study showed that the race-neutral equation is better estimating COPD symptoms than the race-specific equation. What about other diseases? This was a study that looked at asthma. This was looking at the impact of race-neutral equations on children with asthma. They didn't make any correlation to symptom burden or clinical disease, but they had children with asthma and they were trying to see what the impact was going to be in these patients. And they found similar things to what other studies have found, that the values of Black patients were going down. The values of white patients were slightly going up, but not too differently. They also found a decrease in Latinos. And so this was pretty similar to what the other studies had found. I'm also very excited to be part of this story. So this is some of my data that's not been published yet. I was able to work with Dr. Chupp in collaboration with AstraZeneca, who has been involved in the Chronicle study, which is an observational study for asthma, looking at patients with severe asthma at specialist treated academic centers or centers across the US, and looking at what the impact of the race-neutral versus race-specific equations have been on those patients. So these are all patients that we know have severe asthma. And we can see here that Black patients have a significant decrease in their FEV1. White patients and Hispanic Latino patients are going up. However, there was actually a lot of variability in the Hispanic Latino group, and that variability seemed to correlate with what their identified race was, separate from their ethnicity. And here is data from some of the other races that we were able to get, which I think haven't been reported in other places. But in addition to seeing similar trends to what others have shown, which is that FEV1s are decreasing in Black patients and increasing in white patients, we also saw how the classification of their airflow obstruction is changing and their association with FeNO. And we saw that more white patients are being classified with less severe obstruction, but most notably Black patients are being classified as more severe obstruction. And then we also found a difference in FeNO levels, where the FeNO levels are worse in patients, higher in the race-neutral equation, there's higher in Black patients. So that's one of the first clinical variables that we're able to see. This, I think, is really interesting data that I don't totally understand the figure, and if anyone can understand the figure, that would be great. But this is data looking at the impact from lung transplant recipients. So prior to 2020, we adjusted our lung transplants for the specific values of FEV1 and FEC, depending on the disease. And since 2021, those things have been removed. So it seems as though the impact of which equation you use is going to be much less since 2020. But they looked at the 10 years prior up until 2020 to see how people's position on lung transplant and what their lung allocation score was going to be based on which equation that they were going to use. So a little bit more about these graphs. The first line is the GLI 2012, so the race-specific equation. The second is the GLI global, or the race-neutral equation. Dark lines signal someone who's changing both their position on the wait list and their lung allocation score. Light-colored lines are people who are changing their wait list position, but not their lung allocation score. And gray lines are people who are not changing. So first of all, 88% of people are changing in some capacity, which is a huge amount. They found that if the GLI global equations were used, Asian and Black patients for lung transplantation would move forward, meaning that they would be higher priority. They would move about 21 positions on average, or about 4.3 days fewer expected wait time. Hispanic and white patients, candidate would move back about 4 positions, or on additional 1.1 days of expected wait time. The most advantaged patient would move forward 150 positions. And the least advantaged person would move back 5 positions, or 80 positions, and then have 4 fewer weeks to wait. So it seems as though it certainly has impacted, or would have impacted, the position on lung transplant. And it seems to be different now that it's been since 2020. So what are some of the drawbacks of race-neutral equations? So thus far, I think we're seeing that there seems to be correlations with better symptom, better categorization of symptom severity. But what are some of the downsides of using this equation? So it's going to increase the proportion of people that are people of color, especially Black patients, who are, quote, unfit to work in certain occupations. So there's some occupations that require normal spirometry to be able to work there: firefighters, coal miners, and the military. They may be people who were previously categorized as normal and are now categorized as abnormal, that are going to have higher insurance premiums for life insurance or health insurance. And then it's potentially going to impact who is eligible for lung cancer resection. And so we use our spirometry to know whether someone is eligible to undergo lung cancer resection. And I think it's important to note, I'll stop here and say, how much uptake has there been of this new race-neutral equation? So since the official guidelines came out in 2023, it took about a year or so for us here in the Yale New Haven Health System to decide that we wanted to do this, got the technology upgrade to be able to do it, and decided that we were going to implement this change across the health system. So all across our health system, we're now using race-neutral reference equations. There are some exceptions to that. So for example, the occupational health team, who has a portable spirometer that they take to occupation sites, construction sites, or whatever, to do spirometry, that is still running, is not an easy upgrade to their system, because they would need a whole new system to be able to upgrade their program. Just like when your iPhone can't no longer upgrade to the next iOS, you have to get a new iPhone. So without buying a whole new system, they are still running NHANES. So not even having the GLI 2012, but they're actually running the NHANES data. The VA, I have heard, and I would love to hear from VA people, briefly switched to the race-neutral equation and then switched back because they felt that there were veterans who were not qualifying for lung cancer resection. And that felt like a priority for veterans who frequently have lung cancer to be able to get their lung cancer resection. They didn't want to give them that disadvantage. The initial study that looked at COPD also looked at the impact on how many folks are getting occupationally disqualified. This was looking specifically at firefighters, and there is a significant higher prevalence, you can see here, of Black patients now getting disqualified for becoming a firefighter because of these race-neutral equations, and less impact for the other races. So where does that leave us? I think we are left with more questions than answers, unfortunately. How is this impacting other group of patients? I think how much it's actually impacting patients who want to undergo lung cancer resection is a question that I would love answered. I'm doing a study now with Chris Morton looking at how many people are going to be impacted based on their endobronchial valve eligibility. And I think there's certainly more questions about how well this continues to correlate with clinical outcomes. Have we achieved equity? Is this the best reference equation? Is this the way that we're assessing true lung function? I don't think so. And I went to several sessions at ATS last year that agreed. over the last 2 years that agree that this isn't the best way. I think it's a better way. It's a slightly less biased way, but I think that there is a lot to do. There are many people that say we should throw out the reference equations, get a biomedical engineer to just like develop some sort of tool to scan a body and know what your normal lung function should be. I do agree that I think other technology needs to come into this to better assess it. Something that has frequently been brought up as an alternative is measuring sitting height. So your shoulder to hip ratio, is that going to be a better assessment of what your thorax should be? And people at the ATS told me that for some reason it does not match well. And it's very hard for respiratory therapists to find out where your hip is and measure it accurately. And so it seems to be a lot of problems with that as well. And then, as I mentioned, are the race neutral reference equations even being used universally? And the answer to that is no. We know that they're not being used at the VA, at least last I heard. And I'm sure that there are other institutions that are making different choices because it seems to be an institution-specific decision about what each person wants to do. So it's very important if you go to another institution, you look at your lung function tests, and it should on every interpretation paper say what reference equation was used, either the race neutral equation or if it was a race specific, which race was being chosen at that time. I want to make a comment on race-based medicine in general and the problems with it. So a lot of what this started as is a belief that the differences that we were seeing between races were innate and they were biologically determined. And what happens if you do that is that we had then research, both epidemiological and clinical research, that supported those differences between race. We then felt that we're teaching others that racial groups need to be treated differently, and we are therefore creating healthcare biases, stereotyping, and ultimately perpetuating race-based disparities or inequities. And what we should strive for is race-conscious medicine, where we understand that race is actually just a social or power political construct, understand what structural racism is, what the effects of those structural racism is, teach that, provide support to intervene on where those barriers exist, and then ultimately reduce those healthcare disparities. So let's summarize. The race-specific equations for PFTs were based on racist beliefs and ignore the social determinants of health that contribute to lung function. The race-specific equations contribute to health disparities and likely underestimate obstructive lung disease in vulnerable populations. The GLI global, which is the new race-neutral equation, may lessen disparities and may correlate better with disease, but I think there's still a lot of research that needs to be done. And the race-neutral equations are not a perfect solution. And that's all I have. Thank you. I will take questions if there are questions.
All right, thank you very much for this very thought-provoking and enlightening talk. Any questions from the audience? Oh, couple.
I learned so much, Isabel. Thank you. So fundamentally, it sounds like the issue here, aside from the issue of just blatant racism, is that we're trying to use PFTs to help us differentiate between disease and normal variation. And if you just limit it to height and sex, to the extent that that is discriminant, we're still left, as we all know, with like this huge variation of what we're calling normal, to the point that leaders of difference in vital capacity, and you've got people who may even be abnormal by test who don't have a disease. And so I guess that what it means is that anything that gets you closer to better discrimination would be worthwhile. And I think what you pointed out is self-identified race or is not helpful for all the reasons that you said. But I'm wondering, do you have any thoughts about other factors that might help make pulmonary function tests more discriminate? So for example, would it be helpful to understand the genetic background if genes actually did impact this? Or are there other factors that we're not considering that might help us discriminate normal and abnormal?
That's a great question. And I think the problem is that even if I know what factors may contribute to what your normal may be, I don't know statistically what percentage, right? For example, I saw a new asthma patient today, 20 years old, and she reported a ton of respiratory infections in her toddler years and ultimately tons of asthma symptoms since then. So do I think that those early infections contributed to what her normal values of lung function should be? Absolutely. But does that mean that I'm moving her FEV1% predicted down by 5%, by 10%, by 20%? I have no idea. Even though I know these things impact what your lung function should be and what it's going to grow to be, I have no way of knowing percentage-wise how much to decrease it by. And so including more social determinants of health in our studies is going to be really important to figure out where these normal variations are and to see how much impact something has versus something else. Again, what infections, how long they were sick. There's so much variability or heterogeneity there that it's going to be hard for me to make a recommendation of, if we look at these environmental factors, but this is by how much we're going to decrease or change move our reference ranges, because it's hard to know. I think that the real solution is to have a different way, aside from needing to compare you to a normal population, because I'm never going to have 100,000 Mark Siegels to compare your normal lung function to, right? And so what characteristics about you should I look for when I'm thinking about what normal variation I should compare you to? Some people have said maybe we should make everyone get PFTs when they're 18 years old, and so that when you're 50, we can know what your lung function was and how much it's deteriorated and how much has changed. But again, not all 18-year-olds have normal lungs, right? Because a lot of things happen to them even in those early years. I think a different way of scanning you or looking at you or measuring or something needs to happen, because I don't think there's any way to have a reference population that's really going to be representative of the amount of diversity and heterogeneity that we have between all of our patients.
Hey, Isa, that was really cool. Thank you. It's a fascinating topic. I think you showed very clearly how if you take the race neutral versus the race-based equation, there's a separation. But I wonder if you were to make a comparison and then multiply that comparison by sex, for example, would you have a wider difference? Like, is there a wider difference in that? I mean, would the race neutral equations be equally effective if you compare them by sex? If you did a subgroup analysis of male versus female, would they be equally effective at reducing that disparity? Or would there still be a difference that is sexually dimorphic? I guess it's my question.
So we already, if I'm understanding your question correctly, we already account for sex in our PFT interpretations. And are we doing that well? Another great question. This was only specifically looking at the data for the race correction, which started at a very problematic place and had very not great scientific data to support it. And so how we adjust for gender is an amazing question as to how that came to, I mean, I think noted differences early in the earliest observations, even in 1840, but what the percentage of adjustment that's being made and is that appropriate? I don't know. Hope so. Thanks.
All right, there's a question from Richard Mattei in the chat. What approach has the UK taken on these equations, and what is the basis of its decision? For in the UK, there's a wide range of races as in the USA, and has the ERS taken a stand on these equations? I want to add to that question. What do you see in other parts of the world?
Yes.
Which equations does Hong Kong use?
Yeah. I don't know what equation New York uses. I don't know what equation California uses. So I have no idea what they do in Hong Kong or in London or in Tokyo or any other place. I really have no idea. And I wish there was more transparency as to what that was, especially since this race neutral equation and understanding how much controversy there was even in the official ATS statement being made. And therefore knowing that the uptake of actually using it might not be universal. Also knowing that there's a lot of systems that are still using the NHANES data, which is now two recommendations ago. And so I think that there may be a lot of places globally that are not using the most up-to-date reference equations. And if they're not using this race-neutral equation, they are absolutely using a race-specific equation of some type, whether it's GLI 2012 or NHANES. I don't know what stance the UK has had. I know that they have been involved in the studies for the impact of what these new race-neutral equations means. So there must be some people in the UK that care to know, which I find encouraging. The data that I showed about lung transplantations included a UK database, but I really don't know what each institution is doing, and I think that is a problem. I think you ideally should be able to look it up, and I don't think there's any way to know, no matter how many Google searches you do, are they using now the GLI Global? I don't know.
And do
Naftali
you,
believes it's true. And Naftali
following
believes
up
they
on
do.
that, do you think that the sample they used to come up with this equation is adequate representation of all the lungs in the world? Or is
Very
it-
easy to answer. Absolutely not. I will say that the GLI data included a large proportion of African American patients, which they intentionally coined African American because they were very, very few people from Africa, from the subcontinent of Africa. And so we know nothing about what their lung function is and only know about the lung function of those that live here in the United States and have a different historical background. And so while I think the GLI, especially compared to NHANES, was a big step in the right direction of getting a more global perspective and many more countries were included, the majority were still white Americans and Europeans. So that's part of the problem.
So actually, can you comment a little bit about the potential other ways to determine standards? Like I was in a recent NIH workshop, which was discussing basically defining health, lung health across life cycle. So the discussion is that a lot of what we think of is defined by, we start like default is the disease and we go back to normal.
Mm-hmm.
And actually, PFT is one of the things that there was at least an effort to start with normal, but it was done in the wrong term. So there was a huge argument at that meeting between the hyperpolarized xenon MRI people and the CT people. And so what do you think? And is there a way, for instance, if we screen the whole population at the age of 16, and then we just picked the outliers and on them we did imaging, could we generate new standards? Or
I think
so what do you think is the role of the additional novel imaging approaches?
I think that outside of reference equations is where better lung function estimation lies. And the type of imaging, the age at which you do the imaging, the population at which you do the imaging, we create a whole new way in which to image people. I think I don't have an opinion on that, and I would love some very smart biomedical engineers to think about it, but I do think that that is where a better estimation lies because there's just way too many factors, environmental differences between everyone to be able to make assumptions based on a huge group of people. Yeah.
One thing that you mentioned, one of the first slides, there was someone in the 1800s that even was wondering if environmental factors like the climate interfering with their lung capacity. And I was wondering if any of the studies, the populations that you talked about, if they took into consideration like the pressure, barometric pressure, if they were done like at sea level, or if they're higher up, or if the temperature of the weather, humidity also play a factor into that, because obviously, a large population in Africa is under a very warm weather, probably low humidity. But if you go to South America, it might be like higher humidity as well. And here, even the temperature and altitude, if that would interfere with the PFTs.
Yeah. Great question. I don't think that any have looked specifically at high altitude or temperature of weather. I do think there have been some that had looked at pollution exposure, air pollution or air quality. So that has been contributed to. I do want to say that I want to limit how much we extrapolate what your exposure is based on where you are from a nationality perspective, because there are a lot of people that make inferences of why do Black patients have more hypertension? Why do they have worse lung function? Why do they have X, Y, and Z diseases? Is it because of these things in Africa? And we see that the disease prevalences in Africa change significantly when they come to the United States. And so it really seems like the impact of these structural racist policies in the US, and therefore the subsequent exposures of certain social determinants of health versus others, it's what's impacting their health much more. And so even if I'm a person from Peru, the climate of Peru is not in my blood determining my health, it's more what my exposures are now. And then again, I might move to California tomorrow, I might move to Vietnam tomorrow, and therefore my exposures are then going to continue to change. So I think we need to know what are the impacts, how much is air quality, how much of a bad air quality is going to impact your lungs and how much does this social determinant impact your lung function? And then what is a different way outside of, let me compare you to 100,000 other people that are really not much like you at all? I don't think that's the way to know what your lung function should be. Yeah, thanks.
There's another comment and a question in the chat from Luke Davis. Thank you for a superb talk. Outside of situations like lung resection, it seems to me that the rate of change in an individual's lung function is a lot more important than how they compare to quote unquote normal. Do we have too much emphasis on normal?
Great question. Absolutely. I hope that we all, especially as pulmonologists, are looking at the rate of change, and that certainly matters. I hope that nobody is hearing a very symptomatic person and looking at normal PFTs and being like, bye. I think we're all thoughtful and very much, what am I missing? What is this not accounting for, et cetera. But I do think that there are some hard lines in the sand in certain places. The disability claims, the life insurance claims, the lung cancer resection, wherever we have a grading system of this is the cutoff you need to meet, in my opinion, we need to change where those cutoffs are now. And so even though I agree that as we as pulmonologists treat patients as a whole, someone else who is looking at your very first PFTs may make assumptions incorrectly based on what they're seeing, maybe classifying things differently, and then it may have you miss opportunities or place you in a different place to get certain things. And so there are some places in which there are lines in the sand in which the initial PFT values do matter. And clinical trial eligibility was another one that I'm just remembering now.
Another comment that I think has been hinted in by this discussion is the context in which we're interpreting PFTs, right? It's not just an issue of generating large databases. What you really want to do is make good decisions for your patients. And so I imagine, for example, if you're going to say yes or no to lung transplant, or yes or no to lung resection, or yes or no to insurance or a job, you probably want to have some sort of Bayesian reasoning here in terms of how likely is it, for example, if this person is going to take an undue risk becoming a firefighter based on everything I know about this patient, not just a single number that says they're going to get the job or not get the job. And it sort of reminds me a little bit of when you have these people with borderline PFTs and have them do a CPET prior to doing lung resection, that maybe that's the way we should at least think about it in the interim until better methods come around.
Yeah, I think knowing about this, knowing where we have come from and where we are now, and still the limitations that we still exist, and always the whole clinical context of what's going on with the patient is going to be the most important. And knowing, just similar in the pulse oximetry story of skin pigmentation, knowing that the pulse ox result you're seeing, maybe I need to think extra about it. So that's still true for our PFTs. Thanks.
All right, thanks. I think this was a very thoughtful discussion. Thanks again, Isabel, for presenting this. And we'll give you another big round of applause. Thank you very much.